Hello, Dr. Deirdre here. I've covered COPD as a disease in part 1 and the management thereof in part 2, and I've done this all according to the updated GOLD guidelines of 2024. The best way to learn and to remember is to actually apply your knowledge. I'm doing this case study merely as a learning exercise and definitely not to point fingers. Also remember that the various healthcare professionals can interpret a case differently, and you might not always agree with me, which is fine. It is just important to work together as a team and to collaborate to ensure that the patient benefits. What I had available was the doctor's notes, laboratory results, and the patient's full medical insurance statement while in hospital. I have kept everything anonymous to maintain confidentiality. I will walk you through the case and point out some matters. So let's look at the scenario. Patient EFM is female, and at time of the incident she was 87 years old. Her daughter noticed she was struggling to breathe and decided to take her to casualty, whereafter she was admitted. She had a hemorrhagic stroke in 1985 and underwent a major brain operation. She has recovered well but had a seizure which was observed by a family member approximately 18 years later, which might have been due to an epileptogenic foci. She was, however, stabilized on her chronic medication since then. During COVID, she was hospitalized for a bleeding ulcer brought about by smoking cigarettes bought off the street. Approximately 2 years ago, she was dyspneic and admitted to hospital. She received oxygen and discharged the next day. She complained of a tight chest at times and used a SABA, salbutamol, when needed. Patient EFM is up to date with immunizations including influenza and pneumococci. Social history: she stays with her daughter and is well taken care of. Patient EFM has lost muscle mass due to inactivity and sits or lies down most of the day. Although she eats her food, she weighs a mere 40 kilograms, and she has been smoking for most of her life, up to 1 pack per day. And she has, however, lately been trying to reduce the number of cigarettes to 6 to 10 per day. This is a list of her chronic medication that she is stabilized on, and there is no known allergies. We can view the doctor's notes indicating the comorbidities of hypertension, hypothyroidism. The patient said she stopped smoking, which is not quite true, so that is questionable. The patient presented with cough, dyspnea, and chest pains, which are signs and symptoms of COPD, yes, and the provisional diagnosis was prospective exacerbation of COPD. Her blood pressure was raised, 158/71, most likely due to the stressful situation. Then more tests were requested according to protocol, I presume, to rule out any alternative diagnosis, including congestive heart failure, bronchiectasis, and tuberculosis, and respiratory viruses, as well as urinary tract infection, to rule all of those alternative diagnoses out. To rule out pulmonary embolism, a D-dimer was requested, as well as more tests to ensure that the heart is fine. The doctor noted the patient had the reduced body mass index and requested a dietitian to intervene as well as a physiotherapist to help with the phlegm. So the specimens collected on the 5th of March showed that there was no viral infection, and the D-dimer was raised, but a D-dimer result is not specific, and it can also be due to chronic illness and prolonged bed rest and renal insufficiency. The patient is 87, so this applies to this patient, which might be the reason for the increased D-dimer. So here we continue with the specimens taken on the 5th of March. The potassium was within normal range. I'm just highlighting it for later on. The serum bicarbonate was within normal range. It was towards the upper limit, and the serum creatinine is also within limit, so normal kidney function. What was raised was the glutamyl transferase, the liver function test. So this enzyme, liver enzyme, was raised, but it might be due to carbamazepine, and the smoking of cigarettes can also increase this enzyme. So this is applicable to the patient. Then C-reactive protein. See, it was on admission, it was fine. The patient did not have a raised CRP, and the doctor also noted normal CRP on the 6th of March. Then if you look at the vital signs of this patient, all of it is within normal range. You see the temperature, 36 degrees Celsius, and a blood pressure, heart rate, respiratory rate, so that's all within normal rate. These lab results indicate normal vitamin B12, normal ferritin, thyroid normal, heart enzymes normal, so myocardial infarction could be ruled out. There's a slight rise in the inorganic phosphate and a slight decrease in total protein and albumin. On the 8th, 3 days later, the doctor still suspected infective exacerbation, even though the vital signs are all within normal range, no increased temperature. The MAP was within normal range, the mean arterial pressure, indicating that there's sufficient perfusion to the tissues. And according to the GOLD guidelines, the diagnosis of COPD is made based on the patient's symptoms, history of exposure to risk factors, and then confirmed by pulmonary function tests such as spirometry. So on the 11th of March, we see that this patient's vital signs are still remaining within normal range, and that the urine sample collected on the 10th of March showed that no bacteria were present and there was no growth. Remember the potassium that I highlighted in the beginning. Upon admission, the patient's potassium was within normal range, and now it is reduced, is below the normal range. But what could be the possible cause for this? This patient has been prescribed a beta agonist in the meantime, a long-acting beta agonist, and it is known that beta agonist shifts potassium intracellular due to an effect on the membrane-bound sodium-potassium ATPase pump, and this is most likely the reason for the patient presenting hypokalemic at this stage. This patient's red cell indices are normal, but the erythrocyte count, hemoglobin, and hematocrit are reduced, and these elements are decreased in anemia and hemoglobin, especially in iron deficiency anemia. This must be corrected because hemoglobin is a transport vehicle for oxygen and carbon dioxide, and this patient is presenting with dyspnea. Furthermore, hemoglobin serves as a buffer by shifting chloride in and out of red blood cells according to the level of oxygen in plasma, and this patient presents with a reduced chloride level. This is an illustration of the shifting of these elements and how one element can affect another, and also how your body maintains homeostasis. The neutrophils and the monocytes are raised, and this can be infection marker, as neutrophils are the most abundant white blood cell, and they defend against microbial invasion, and an increase in the number of neutrophils parallels the severity of an infection. Monocytes are the largest cells in the blood and serve as the body's second line of defense. So this is an infection marker for patient AFM. On the 12th of March, a urinary tract infection was noted in the patient's file. However, you will recall the urine sample that was collected on the 10th of March and showed no growth. The CRP is raised. It's now raised quite a bit on the 11th of March. But as we know, a C-reactive protein is not specific for a bacterial infection. Regarding CRP, it is a protein made by the liver and released into the bloodstream in response to inflammation. It is a non-specific marker. Procalcitonin, however, is regarded as a biomarker specific for bacterial infections. It is helpful in the diagnosis of sepsis and to guide and monitor antibiotic therapy. This patient's PCT was 0.10, and it indicates that infection is possible. This is the patient's oxygen use while in hospital, and it is a key component of hospital treatment of an exacerbation. Unfortunately, I do not have access to the patient's medicine chart and will therefore not discuss each and every item the patient has received. However, this statement received from the medical insurance will give a good indication what the patient has received when. First of all, the medication that the patient has been stabilized on, I have cancelled out on this document. We note that the patient has received ceftriaxone upon diagnosis of infective exacerbation of COPD, and ceftriaxone is a third-generation cephalosporin, which is a broad-spectrum antibiotic that covers gram-positive organisms and is good for most gram-negative organisms, but not for Pseudomonas aeruginosa, Enterococcus species, or the anaerobe Bacteroides fragilis. A question that should be asked is, was an appropriate specimen taken for culture and sensitivity tests before initiation of empiric antimicrobial therapy? Because this is one of the basic principles of antimicrobial stewardship. Around the 11th of March, the patient received meropenem, which is a carbapenem, also a broad-spectrum antibiotic active against gram-positive and gram-negative aerobic and anaerobic organisms, including Pseudomonas aeruginosa, but it's not active against chlamydia species, MRSA and MRSE, Mycoplasma pneumoniae, and Enterococcus species. More or less 2 days later, the patient received amikacin, which is an aminoglycoside, and also a broad-spectrum antibiotic active against most gram-negative organisms, but not against Streptococcus species or anaerobes. This is a list of items the patient received from the ward stock. And ceftriaxone was also dispensed from ward stock on the 6th of March. But I will give you a summary towards the end so you can see what antibiotics the patients received when, either from the pharmacy stock or from the ward stock. More items received from ward stock. The patient received yet another carbapenem, doripenem, and this means that the patient has received ceftriaxone, meropenem, amikacin, and doripenem sometime between the 5th and the 13th of March. Because remember, I haven't got the patient's medicine chart, and this medical insurance statement is just an indication, or just tells us which antibiotics the patient has received. So since admission on the 5th of March to the 13th of March, the patient has received quite a number of antibiotics without determining the actual bacteria to target. With the antibiotics administered to the patient and taking the patient's laboratory results and vital signs into consideration, we should ask ourselves, does this hospital have an antimicrobial stewardship team to create guidelines for antimicrobial use and to ensure these guidelines are adhered to? Also, does this hospital have an antibiogram to summarize the percent of individual bacterial pathogens susceptible to different antimicrobial agents? You can watch this video on antimicrobial stewardship. Then regarding the principles of antimicrobial stewardship, was the initial antimicrobial therapy appropriate? Surely the doctor used the hospital's protocol to treat patients with acute exacerbation of COPD, but this is also where an AMS team can play a role to ensure that the antimicrobial agents are used appropriately and that it's individualized for the patient. With the initiation of the empiric therapy, no appropriate specimen was taken for culture and sensitivity tests. And not having that, the antibiotics will not be able to be de-escalated from a broad spectrum to a narrow spectrum agent. Also, the intravenous to oral switch. The patient was able to take medicine per os. She was prescribed many items taken via the oral route, like her theophylline tablets, Bel Air tablets. She was still taking her chronic medication via the oral route. So surely the patient could have taken antibiotics also via the oral route, or there could have been an IV to oral switch. This is the prescription the patient was discharged with. Single layer contains montelukast, which is indicated for prophylaxis and chronic treatment of asthma. This patient does not have asthma and, in my opinion, should not receive single layer. Texa contains cetirizine, which is an antihistamine. This patient does not have any allergies, and the eosinophil count also does not indicate any allergic reaction. In my opinion, Texa should also not be on the prescription. Is this perhaps an example of polypharmacy? Theophylline, according to the GOLD guidelines, should be considered for patients who are intolerant or unable to use an inhaled bronchodilator. Also keep the chronic medication in mind that the patient is already on, and we will find a drug-drug interaction between carbamazepine and theophylline. Safer options are available to use. Also, while in hospital, no TDM was done, and dosage adjustments of theophylline should generally be made based on serum concentration results. In my opinion, theophylline should also not be on this prescription. Regarding the addition of azithromycin to the prescription, current guidelines recommend to only consider the addition of chronic azithromycin for patients with recurrent exacerbations despite optimal therapy and who are not active smokers. This patient hasn't been treated optimally, as she only used short-acting beta-2 agonists when necessary before she was admitted now for an acute exacerbation of COPD. She is furthermore still a smoker, and there are also drug-drug interactions with her current chronic medicine. For these reasons, I disagree with the addition of azithromycin to the treatment regimen. What is left on the prescription is an inert corticosteroid combined with a LABA and a LAMA. The patient most likely falls into group E, and according to the GOLD guidelines should be prescribed a LABA plus a LAMA, and if the blood eosinophils are more than 300, an inert corticosteroid can be considered. This patient's eosinophil count is 480 cells per microliter and therefore falls under the strongly favored use for an inert corticosteroid. What is missing or omitted on the prescription is a rescue short-acting beta-2 agonist, which according to the GOLD guidelines should be prescribed to all patients for immediate symptom relief. Well, this was quite difficult to do a case study online with no interaction, but I hope you could follow and that it was meaningful to you. Many of you would have looked at the case study from a different angle, so you are welcome to leave your comments below. I really think a clinical pharmacist plays a vital role and should be part of the multidisciplinary team, and that we should work together for the benefit of the patient. Until next time, thank you and bye-bye.